I just thought I'd do a quick video talking about cholinesterase inhibitors, which raise the acetylcholine level in the brain. Drugs like rivastigmine and donepezil. Donepezil is the most commonly used. These medications are licensed to treat Alzheimer's disease, but also can be effective in Lewy body dementia. So the way they work is they essentially increase acetylcholine in the brain by blocking the enzyme that breaks it down at synapses. So at the base of the brain there are or the top of the brainstem, there are some nuclei that send axons up to the surface which secrete acetylcholine, and the theory is that will improve memory and cognition. So if the neurodegenerative process in Alzheimer's, for example, kills off those nuclei, then you end up with potentially a lack of acetylcholine in the brain, so we try and boost it up. There are studies that suggest that this works to an extent, and the rough theory that I would tell patients is that it will, if you think of a downhill slope, slow, shallow slope in dementia, that you're going downhill slowly, if you can't cure it, the best you can potentially do is flatten it off for a while, so you could be down and then flatten it off. Maybe that effect could last for maybe a year or so, but it's not set in stone, and the benefits are generally quite modest. So, question with all drugs is, what are the side effects? So in other words, how would you do informed consent in a circumstance like that? The way I generally talk about it is that if you think about acetylcholine being the main neurotransmitter of the parasympathetic autonomic nervous system, if you boost it, then you effectively have a sort of parasympathetic bunch of side effects. So if you think about, for example, the bladder and bowel, their activity is increased by acetylcholine, so people can potentially get side effects like an increased urgency with their bladder. They may have tummy upsets and abdominal pain or diarrhea, but we generally start the dose of donepezil low, so the half dose is 5 milligrams daily, and we might give that for a few weeks to see if people can get used to it and tolerate the drug. Another thing that the parasympathetic system does, as you probably know, is if you have a heart which has no nerves to it, so denervated heart, a heart will beat about 100 beats a minute. So the parasympathetic supply to the heart when you're relaxing is you get a heart rate of say 60 or 70 beats per minute that way. So if we increase acetylcholine, you can obviously have a bradycardic response. So if a patient, for example, has a pre-existing heart block and a pulse rate of 45, they're not probably going to do too well on a cholinesterase inhibitor. So you have to pick your patients. Equally with the medications, what they can do sometimes is increase things like mucus production in the lungs, so you wouldn't want to give it to someone with brittle asthma, for example, or maybe severe COPD who is a patient repeatedly needing steroids, because then you could potentially make them worse. And it also can increase stomach acid, so cholinesterase inhibitors are generally contraindicated in patients with peptic ulcer disease that's active, so you've got to be careful. So when you have these known logical side effects in your mind, you can easily do informed consent on patients for drugs like donepezil. Typically, also the other key thing is they work best, and the evidence suggests they work best in people who are in relatively early or they have mild features, so someone who's got advanced features, who's, say in residential care because they're really quite impaired. Those people are going to have very much less benefit in general, and therefore the side effect versus benefit ratio will probably outweigh, and you wouldn't want to use it. It used to be that you had to show an improvement in the MMSE of, I think it was 2 points some years ago, to be allowed to keep prescribing the donepezil, but that no longer is valid. What you now need to show is this very vague thing called a subjective improvement in the patient. But in reality, most people get left on these drugs for long periods of time. Their benefit is probably months to a year or something of that nature. The hard thing about coming off them, though, is that if you take someone off the drug, there's a fear that you'll have a rebound, or not a rebound, an acute drop as soon as you stop the medicines, and there's a fear around that. Anyway, they're probably the key things you have to know about those medications for Alzheimer's. And as I say, they work pretty well in people with Lewy body. Sometimes they work actually potentially better in people with Lewy body disease. If I think of anything else, I'll keep you posted. Thanks.